tu. Dengar?
Waalaikumsalam warahmatullahi wabarakatuh. Dengar doktor.
Okay, kita mula dengan ulum kitab Al-Fatihah. Okay, boleh start lah. Sorry lah lambat. Banyak kerja sikit lah. Okay, present. Saya nak present tanpa tengok slide, tengok kertas.
Okey, boleh doktor.
Okay,
Boleh insyaAllah.
kalau boleh berdiri lah. Biar ada bukti awak tak tengok apa-apa.
Apa doktor?
Kalau boleh berdiri. Sambil berdiri. Standing.
Berdiri.
Yes.
Oh. Okey.
Okay, tak apa. Tapi awak kena jujur lah. Tak boleh tengok kertas, tak boleh tengok apa-apa.
Okey, saya try doktor.
Okay, boleh start.
Nota pun tak boleh tengok tu. Okey, saya start. Bismillahirrahmanirrahim. My patient, Aira, 3 years old, 3 months, Malay girl, was presented to emergency department of suspect with a complaint of fever and diarrhea for 1 week duration. And for the history of presenting illness, Aira was apparently well until a week ago. She developed fever. She developed a sudden onset of fever. The fever was warm to touch. However, there is no temperature recorded at home. And the fever was on and off. And the father claimed that the fever was worse during the first 3 days of the fever, but it was continuous throughout the whole week with no period of resolving. And the fever was associated with cough and runny nose. And otherwise, the fever was not associated with any rashes. There is no mucosal bleeding. There is no history of fogging. And the patient does not live in dengue-prone area. And on the day 3 of the fever, her father, Aira's father, took her to a local clinic where she was prescribed with an antibiotic treatment. And after that, the cough and runny nose was resolved, but the fever still persists. And 2 days after given antibiotic treatment, Aira started to pass loose stool. The stool was watery in nature, and associated with a streak of blood. And she would pass stool about 8 to 10 times per day. And since then, she had been less active, and her father also noted that her eyes was a bit sunken and her lips was a bit dry. However, her father was unsure about the urinary output as it occurs along with the diarrhea itself. And her father also was unsure about if there is any polyuria or any presence of hematuria. And since the diarrhea also, Aira had been reduced in oral intake, which she usually before this she usually eats about 3 times per day, but during the episode of diarrhea she refused to eat and would only drink and only tolerate with drinking. And however, her father denied any history or any episode of vomiting, any history of eating outside food, or any family members with similar symptoms. And her father also denied any history of recent traveling outside of Kuantan. And Aira does not go to any daycare center yet. And for the systemic review, for cardiovascular system, there is no paroxysmal nocturnal dyspnea, there's no chest pain, there's no orthopnea, there's no palpitation. for the CNS, central nervous system, there is no confusion, there is no seizure, and there is no altered mental status. For musculoskeletal, there is no arthralgia, there's no myalgia, and there's no any complaint of muscle weakness. For the past medical history, um, patient had a history of hospitalization once when she was 2 years old due to measles infection. Otherwise, patient does not have any known medical illness or any surgical history. For her birth history, prenatally, um, her mother does not have Irah was her mother's first pregnancy, and during the pregnancy she does not have any medical illnesses such as hypertension or diabetes. And for the antenatal history, Irah was born late and was born by cesarean section, and her birth weight at that time was 3 kilograms. For postnatally, she had no complication except for having mild jaundice and was hospitalized for 2 to 3 days due to the jaundice. And for her immunization history, her vaccination, according to her father, her vaccination was up to date. And for the nutritional history, Ira would eat 3 times per day. She eats adult's diet, which consists of nasi and lauk, and she is a picky eater. She dislikes eating vegetables. For her developmental history, her development is suitable for age. As for the gross motor, she can stand on one foot, she can go up and down stairs, and for her social, she can dress and undress. She can undress and undress herself, but still needs help. And for her speech, she can count to 10, and she can speak in phrases, and she can also recognize colors, such the main colors such as the red, blue, green, and yellow. For family history, Ira is an only child in the family, and her father and mother had both her parents had no known medical illnesses. And for her social history, she lives with her parents and also grandmother at IM8. They live in a two-story house, two-story terrace house. And her father runs a business while her mother is a housewife. The total household income was about 4 to 5 thousand per month, and her father does not involve in any um, unwanted behavior such as smoking or taking alcohol. That's it. And for the summary, my patient, Ira, 3 years old, 3 months old, Malay girl, was presented to emergency department of SASMED with a complaint of uh, diarrhea and fever, which was associated with respiratory symptoms. The diarrhea was watery and was associated with streak of blood with with and there is signs of dehydration. Other uh, uh, with signs of, and that's all. My provisional diagnosis would be acute gastroenteritis secondary to bacterial infection.
Ada differential?
Ada differential. My differential diagnosis, I divide it into parenteral causes and also enteral causes. For the parenteral causes, my differential would be dengue fever and also pneumonia. And for the enteral causes, would be food poisoning, would be hemolytic uremic syndrome, and intussusception.
Good. Very good. Okay, that's very good structured way of answering question lah. I mean, provide your differential diagnosis. Okay, anyone got questions about the history? Anyone?
Is there any sick contact with other sick patient?
Sick contact. Regarding the diarrhea or regarding the respiratory symptoms?
Respiratory.
Respiratory tak tanya. I forgot to ask.
The diarrhea?
The diarrhea, there's no sick contact. There's no sick contact with any patient of diarrhea because family does not have any symptom of diarrhea, and also she does not went to any daycare center. She stayed with her mother, with her grandmother. So her grandmother took care of her.
Okay, Nur Ildina Nabila, I have got one question. What is the presenting complaint?
Hello,
Hello, huh?
getting complaint. Diarrhea.
Ya ke Masawa? Presenting complaint diarrhea.
Yes. Diarrhea and fever and diarrhea.
So diarrhea tu berapa hari dah?
Since 1 week.
Kan, diarrhea tu dah 1 week. So kenapa patient tu baru datang hari ni?
Because it does not resolve. Dia tak macam continuous.
Ya ke because
Patient
of diarrhea dia datang? Is it something else?
Patient kata dia datang tu sebab diarrhea dia continuous, tak hilang-hilang.
Tak resolve lah. So remember the presenting complaint is not diarrhea. Presenting complaint is persistent diarrhea.
Persistent.
Okay. So it will make a lot of difference. Kalau presenting complaint dia diarrhea dah 5 hari. So kenapa datang hari ni? Okay. Kalau dia persistent diarrhea, then it will be different lah. Maksud dia dah try multiple measures tapi fail. Ataupun it's not really concerning so much. Cuma dia because dia persistent. Faham tak? Kalau diarrhea concerning kan, macam very serious diarrhea, very a lot, and then blood dia very significant, then dia mesti datang at day 1, dia dah datang dah. So usually presenting complaints are things that concern the patient, the parents. Okay.
Doktor,
Afiqah. Ya, Putri Safia, yes.
dia persistent fever juga ke? So do we say persistent diarrhea and fever as well, or just diarrhea persistent?
Tu you kena tanya orang ambil history. So mother dia, which one yang mother dia concern? Because some parents kan, bila anak dah demam seminggu tapi still aktif, dia tak concern pun. And then suddenly develop diarrhea, so dia hantar. Ataupun dia dah diarrhea 1 week tapi sikit-sikit and they still eating happily. And then dia fever, then dia mungkin datang fever lah. Usually presenting complaint ada satu je. Is the reason for the presence of the patient to hospital.
Oh, I see. So in this case, it will be the diarrhea lah, because it's like 8 to 10 times a day.
Tu kena tanya
Yeah,
Musawah.
Is it like that,
Musawah,
Musawah?
which one?
The main concern is the diarrhea because for the fever, when it's like the first 3 days je lah dia macam worse sikit, lepas tu dia dah turun, dia macam tak panas sangat lah.
Okay, alright, thank you.
Dia kan, because patient presented with multiple symptoms and then for quite a prolonged time kan. It's good to have a timeline lah. Okay, you can start your history by give a summary. Okay, ataupun at the end lah summary. You usually bagi summary at the end kan. Tapi sometimes bila HOPI tu, you boleh start macam you boleh cakap patient presented with you boleh start macam ni. Patient presented at day 6 of illness. Okay, with a complaint of 6 days history of diarrhea. Tapi kena ikut flow lah. Dia start dengan apa? Fever. You boleh cakap 7 days of fever, ataupun 6 days history, present complaint lah, complaint diarrhea kan. So 6 days history of worsening diarrhea preceded with fever 3 days prior to the onset of diarrhea. Macam tu. So itu dah okay. So dia datang sebab dah 6 hari diarrhea, and then tapi 3 hari sebelum tu dia start ada fever. Okay. Lepas tu dia sebut cerita pasal diarrhea. Dan lepas tu dia, regarding the fever you ulang balik. Okay, the fever started 3 days prior to the onset of diarrhea. It is initially high grade, but subsequently less prominent, atau subsequently resolve. Okay, after resolve during the 3rd day of diarrhea, ataupun resolve with the onset of diarrhea. You faham tak? Usually diarrhea dengan fever ni dia tak correlate sangat lah, sebab jarang orang datang dengan significant fever with diarrhea except for condition macam dengue atau condition macam typhoid, things like that lah. Tapi kalau biasanya dia more significant kalau fever with rashes. Kalau fever with rashes, you mesti kena ada we call temporal relationship between the symptoms. Especially kalau seizure lagi lah penting. Seizure, the temporal relationship between the activities and also seizure is very important. Contoh, prior to the seizure, patient was playing outside under the sun. Contoh macam tu lah. Ataupun 2 days prior of the seizure, patient has been consuming a lot of chocolate. Benda macam tu lah. So temporal, prior, preceded, proceeded, following, benda macam tu is very important lah. Kalau dia ada multiple complaint. Okay, okay, apa lagi soalan okay, Afiqah Atira. Okay, what is your opinion? Any feedbacks? What's good about the presentation?
My comment would be, my feedback would be, the good thing about the presentation is most of the sign symptoms to rule out the differential is there, most of it, but still there are few that are lacking. Contohnya macam kalau fever tu dia nak tahu macam ada tak difficulty breathing ke, cyanosis episode, macam tadi sick contact, lepas tu worsening at night, facial congestion, lepas tu the stool tu, diarrhea tu dia punya colour kena elaborate lagi kot. Lepas tu patient dia macam doktor cakap tadi, dia presented at 1 week, day 7 of illness lebih kurang kan. Jadi masa kat ED tu nak assess dia punya dehydration status. So macam banyak point yang untuk kita classifykan dehydration punya classification tu tak mention, like macam kalau kat history the tears ke lepas tu ada beberapa yang anterior fontanel saya tak sangka macam tu.
Actually anterior fontanel kan yang contoh benda yang you can assess from history, dehydration you can assess benda macam lethargic, looks thirsty, eager to drink. These are you can ask parents lah. Tapi kalau fontanel tu is slightly a bit difficult lah, because some patient lah you boleh cakap ubun-ubun dia macam mana, selembik ke, but it's relative. Sometimes orang tak tahu pun macam mana. Bulging is relative. So it's quite difficult lah. Yang tu you better assess clinical lah, by clinical. But that's good. That's a very good point. What else? Izzah Zahira?
I think the presentation, as we said before, has mainly covered the chief complaint. But tadi Musawat has said that the fever was associated with cough. So I would like to know more regarding the history of coughing. Is it like a persistent cough, or is it just like one time being? Because one of the differentials that Musawat said is regarding the pneumonia or the respiratory tract infection. So yeah, I would like to know regarding the respiratory symptoms.
Good. Okay, agree. You can elaborate more on the HOPI. Actually, the HOPI can be elaborate lah. Actually, details on the diarrhea is very important. Because sometimes mother may say streak of diarrhea kan. Mother kata ada bloody stool. But actually this child kan, sekejap Amri. Yang, sekejap. You kelab Amri ke Syafiq?
Saya
Nama siapa?
Syafiq, Dr. Syafiq.
Syafiq Syafiq present diarrhea yang intas Oh, okay. So that girl kan, dia punya blood dia, it's not streak tau. It's a mess. It's a PR bleed lah. It's a PR bleed. It's not a streak of blood. That's why it's very important for you to quantify. Cakap. So the way you quantify, you boleh tanya, is it a spoonful, 2 spoonful, a cup, a bowl, a diapers full of blood, macam tu. And then blood tu you kena describe in detail lah. Is it black terry stool kan, melina, ataupun is it more to like lower GI, fresh blood, the smell, is it smelly, benda macam tu. And then ada mucus. It's very important because this child initially we treat as dysentery, okay, but subsequently the features looks like more to acute abdomen surgical causes lah, which I think which finally we think this is interception lah. And then the pain kan, abdo pain. Dia ada mention about abdo pain. You mention about abdo pain.
Ada tadi saya lupa nak present dekat HOPI. Actually
the
ada
patient,
abdominal pain.
Actually the main reason for admission is actually the abdominal pain. I think the main concern of the mother is actually abdominal pain. Dia memang ada diarrhea few days, fever few days, tapi the abdominal pain was that severe, especially during the admission lah, prior to admission tu. It was so severe sampai patient ni memang cramping or forward lah, bend forward. Memang it looks very painful. Looks very typical of interception lah. They got symptom-free period in between, and then ada macam colicky features of colicky-like pain. Okay,
Tapi Doktor, tapi Doktor, from the history lah, saya dapat yang dia kata yang dia diarrhea, yang dia loose stool tu dia macam watery. So itu yang saya macam rasa less likely.
Lah watery, kalau keluar blood je, is it watery? Can someone describe blood as watery? Boleh kan? So sometimes some parents dia mungkin ingat, kalau hitam lah. So dia watery, berak apa? Berak cair. Okay, berak cair. Okay, so kalau kita stop kat situ, berak cair. So patient datang dengan berak cair, diarrhea. But possible it's not diarrhea, it's actually just frank melina. Kan? It's watery, nampak macam watery, tapi it's actually a melina lah, a melanic stool. But sometimes fluid and water, sometimes people get confused tau. Macam contoh kalau I bagi you air Milo kan, you sebut ni watery ke water ke, atau you sebut fluid ataupun fluid lah, liquid. Kalau you nampak Milo, you sebut this is water ke ataupun this is fluid? Liquid sorry.
Water kot.
Water kan. So macam sometimes, tapi air Milo tu you tak nampak air jernih pun. Like, we as a doctor sometimes we think watery means mainly is water lah, is clear ataupun is less particles kan. It's mainly fluid. Tapi some people they think watery is actually air. That's what happen lah. Kalau you tengok gambar dia, it's very prominent macam dark stool. It's mainly blood lah. It's actually mainly blood. So this child was with us quite some time. So KIV yang THTA pun. For surgical intervention lah. Okay. Quite interesting case actually kalau you guys around. Tapi anyway, so okay lah. Lepas tu cukup. Ada soalan? I think in your summary kan, patient case macam ni, it's good to describe the symptoms. You summarize the symptoms. So you boleh buat summary macam ni. So Aira berapa I can remember the most
3 months old.
3 years, yes. Ni memang dia tak cakap orang, dia very reserved. So you boleh cakap Aira years, 3 months old girl presented with 7 days history of, atau boleh cakap presented with persistent diarrhea that preceded with fever, with short duration of fever, ataupun associated with short duration of fever, macam tu lah. Tapi dari bloody diarrhea kan, so bloody diarrhea lah, presented with bloody diarrhea, ataupun blood
terus masuk bloody
diarrhea,
diarrhea.
ataupun diarrhea mixed with blood mixed with blood. Diarrhea consists of blood that mixed with stool, atau ataupun diarrhea that has streak of blood, macam tu lah. Tapi kena sebut lah persistent, word macam persistent. That's why you kena ada banyak vocab tau dalam medical ni. Things macam persistent, intermittent, diffuse diarrhea. Dan kita tahu lah banyak. Atau dia cakap macam cough lah, bouts of cough. Dan kita tahu dia bouts of cough. Kalau sebut persistent cough, continuous cough, tricklish cough, this can be used in your summary. There's satu you boleh cakap macam, there's satu word macam that describe fever, clinical description of fever. Contoh macam quotidian fever, quotidian fever. Kalau rashes, saya suka guna word yang very one word descriptive. Contoh rashes with that were cephalopetal distribution atau centrifugal distribution. Rashes kan, presented with maculopapular rashes that distribute centrifugally. So you just that one sentence, kalau your clinician should understand lah. So you tahu, okay, so datangkan maculopapular rashes centrifugally, start daripada trunk, dia spread to the peripheral. So just one sentence, that's what you call summary lah. Okay, faham kan? Okay, you need to have a lot of vocab by reading lah. By reading you boleh tahu description. Contoh patient datang dengan hypoglycemia kan. So you boleh letak non-ketotic hypoglycemia, symptomatic non-ketotic hypoglycemia. Dan kita tahu, okay, so kita tahu dia hypoglycemia tak ada keton. And then dia symptomatic. So you tak boleh cakap, oh datang dengan symptoms of hypoglycemia such as palpitation, profuse sweating, blah 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 blah. And investigation reveals there's no ketone, no. That be summary is use a concise word lah. Okay, good. Okay, next. Ada soalan ke? Ada soalan?
Okay, nak tanya. So yang patient Airah ni doktor kita suspect dia interception lah, doktor.
Oh yes, I suspect interception.
So kalau yang kita nak tanya, salah satu dia punya striking features lah, red currant jelly kan, doktor. Masa kita tanya parents tu, kita tanya ada anak puan ada ni ke, ada macam dia buang air besar tu, ada macam air besar dia macam jelly merah. Macam tu doktor kita tanya.
Ya, bukan kita tanya red currant jelly. Red currant jelly ni is just description. You cakap je lah, ada tak darah and then jelly separately pun tak apa. But sometimes susah juga red currant. Tapi you boleh, lesson you boleh je sebut red currant, I rasa orang boleh faham kot. Sebab nampak macam blueberry, blackberry ke, macam jelly. Saya rasa okay je. You boleh separately macam jelly, darah, ataupun nampak macam jelly yang berdarah. Okay je, doesn't matter. Because at the end you don't present remarks, parents punya remarks kan. You present your analysis. Okay. It's good lah, sometimes it's good to quote what parents say. Tapi most of the time you don't have to lah. Because we trust you. You tak boleh lah macam, father kata, father describe the cough as woof woof woof. Okay, macam tu, faham tak? For example, you club patient and then you tanya, so bunyi batuk dia macam mana? So ayah dia kata, woof woof woof. So takkan you bila present, you present dekat ayah kata, oh father describe the cough like woof woof woof. Come on, there's no. Yang tu so unintelligent kan? Okay, faham kan? So better you cakap barking cough. Okay, faham tak?
Okay. Faham tak
Okay.
sir? Okay, thank you sir.
Okay, so boleh proceed lah with the next one.
Bismillah. Test. Dengar suara saya.
Dengar dia.
Bismillah. My patient, Yusuf Anaki, a 1 year, 5 months old Malay boy, presented to the emergency department SASMAC for persistent fever of 4 days duration with reduced oral intake associated with lethargy. The history of presenting illness, the patient was apparently well about 1 week ago, when later Yusuf developed runny nose and also cough. The runny nose was with a clear discharge, while the cough was just in nature. Aside from that, there were no prolonged bouts of cough. There was no barking cough as well as whooping cough. On the second day of illness, there was an episode of post-static vomiting. The vomitus was yellowish in color and is of milk content. There was no blood noted and the vomitus was non-bilious. Yusuf later developed a low-grade fever about 4 days ago. The fever was persistent in nature, usually at about 38 degrees Celsius. But then prior to admission, the temperature peaked at 39 degrees Celsius. Yusuf was given paracetamol at home, but then the fever did not subside. I'm sorry, but the info was taken from the adopted father, not the biological father. So the adopted father's name was Amri, Mr. Amri. So Mr. Amri denied any incidents of watery eyes. There was also no ear discharge and difficulty of sleeping. Yusuf also started to have reduced oral intake at the start of the fever, when usually Yusuf would drink 5 ounces of milk up to 6 times daily, but apparently he would only drink once. Subsequently, 2 days ago, Yusuf had stopped even eating solid food, which normally he can consume 3 small meals of porridge, but now Yusuf would reject any porridge that was given. Mr. Amri did mention that Yusuf's throat was red. However, there was no history of tachypnea, bronchi, nor stridor. Yusuf was then taken to a private clinic one day prior to admission to check for his fever, and he was prescribed with PCM and also antibiotics 3 times daily. According to Mr. Amri, there were no rashes noted to be on Yusuf's body. He also denied living in a dengue-prone area, and there was no history of recent fogging. Mr. Amri did mention of sending Yusuf to a daycare every day at weekdays. However, he was unsure if there was anybody at the daycare with the same symptoms. Additionally, both Mr. Amri and his wife were also free from any of the same symptoms. There was no history of recent traveling, as well as outdoor recreational activities. Prior to admission, Yusuf had his temperature checked, and it was 39 degrees Celsius. However, according to Mr. Amri, there was no signs of dehydration, such as reduced tears, reduced urine output, as well as dried lips. Nonetheless, Yusuf was getting more and more lethargic since he stopped eating, and subsequently Mr. Amri brought Yusuf to the emergency department SASMAC. So for system review, generally patient had no loss of weight for his head and neck. There was no neck stiffness. There was also no neck swelling. For his cardiovascular, there was no dyspnea, PND, as well as optopnea. Respiratory, there was no history of hemoptysis. his GI, there was no hematemesis, melena, as well as abdominal pain, genitourinary. There was no history of dysuria, hematuria, as well as loin pain. Hematological, there was no purpura, gum bleeding, and epistaxis. There was also no history of seizure, abnormal movement, as well as weakness at the upper and lower limbs. For Yusuf's past medical and surgical history, previously Yusuf had been warded at Susmek when he was at 11 months old due to a case of tonsillitis. Otherwise, there was no history of admission and surgical intervention that was done before. For his drug history and allergy, history, Yusuf has no known drug and food allergy. He is on PCM 6 hourly, as well as a course of antibiotic, which he had taken 3 times prior to admission. 3 doses prior to admission. For his birth history, Mr. Amri didn't really know Yusuf's birth history, except that Yusuf was born full term via SVD. Otherwise, Mr. Amri denied any postpartum complications. For his developmental history, Yusuf is an active child. He is able to walk unsupported. He is able to feed himself with his hands, as well as doing circular scribbles. For his speech, Yusuf is able to say a few common words such as mama and baba, and he can understand simple words such as makan and tidur. For his social development, Yusuf responds upon calling his name. For his nutritional history, Yusuf started formula milk very early in his life, starting during his first month. Mr. Amri claimed to have been given Yusuf pediatric formula milks ever since he is adopted. Yusuf was also not breastfed by his adopted mother. Yusuf started weaning at 6 months old. He was started with plain porridge, and then step by step, Mr. Amri added chicken, salmon, as well as broccoli in Yusuf's diet. Yusuf is not a picky eater. For his immunization history, he took immunizations up to his age according to the immunization schedule by the Ministry of Health. For his family history, Yusuf was adopted since he was 21 days old. The adopted parents was unable to conceive a child for a very long time. And at the same time, Yusuf's biological parents were also looking forward for adoption. So both of his parents and the adopted parents are still in contact. Yusuf's biological parents currently living in Besut. Mr. Amri and his wife are currently working as policemen and policewomen. Mr. Amri is 34 years old, while his wife is 35 years old. Both of them are non-smokers. Other than that, both Yusuf's biological parents as well as his adopted parents have no non-medical illness. For Yusuf's social history, he is an active child. They live in Kempadang. Yusuf lives in Kempadang with his adopted parents in a terrace house with complete basic amenities. The house occupants has 3 people, including Yusuf. The total household income is about 4,000 monthly. The nearest primary care clinic is a private clinic, but I am unsure of the name, which has been one of their main clinics to go for. Yusuf was even sent to the nursery every weekdays, since both of his adopted parents are working every day. That's all. I think my history. For my provisional diagnosis, I think with Yusuf's presentation, he might be having acute tonsillopharyngitis with poor oral intake. For my differential, it can be viral fever, it can be viral pneumonia, as well as acute bronchiolitis. Due to the respiratory symptoms as well as the current presentation. That's all. That's all from me.
Okay, good. So any comment? Fika, Tira.
Comment. Overall is good, but saya perasan satu tadi ada repetition sikit dekat yang pasal yang temperature recorded tu, kat atas ada mention 13, bawah pun dia repeat lagi. Lepas tu dekat history mungkin ada beberapa point yang tak disebut, contohnya sebab patient present with fever kan. Lepas tu macam ada tak history of say contact with COVID patient ke. Lepas tu dia mention pasal chesty cough, so I would like to know more about the cough, macam colour of cough ke, ada sputum ke. Lepas tu macam is there any episode like this before happen to this child? Macam is this the first presentation ataupun pernah macam repetition ke? Sebab tu penting untuk differentials, macam contoh kalau cystic fibrosis, immunodeficiency. I think that's all. Lepas tu and juga kita macam nak kena classifykan severity of the pneumonia. That's all, doktor.
Macam mana you nak classifykan severity of pneumonia?
According to PITS-UM, there are 3 mild, severe and very severe pneumonia. Lepas tu dia ada, kalau mild tu biasanya kalau patient ni umur berapa?
Setahun 5 bulan.
5 bulan? Setahun 5 bulan?
Setahun.
So kalau dia ada 2 classification, kalau less than 2 months another classification. Kalau patient ni kalau dia ada severe chest indrawing, rapid breathing, tu severe pneumonia. Biasanya kalau mild pneumonia tak ada apa-apa symptom dia not very prominent. Kalau very severe pneumonia sampai tak makan, ada convulsion, abnormally sleep and difficult to wake. Lepas tu hypopnea with slow irregular breathing.
I forgot to mention takut tadi. Yang chesty cough tu ada sputum production. It was clear. The color was clear. And then there was no incidence of tachypnea. So therefore I think it would not be severe pneumonia, classification of pneumonia tadi.
Could it be bronchiolitis?
So,
One of your differential is bronchiolitis kan?
Doctor.
Could it be bronchiolitis?
I believe it can be.
Macam you diagnose bronchiolitis?
Kena ada wheezing, Doctor.
Ya, kena ada wheezing. Is it not compulsory to have wheezing ke bronchiolitis? Most bronchiolitis ada wheezing pun actually. It's not something yang wajib ada tau. Ada wheezing. Macam ni nak diagnose bronchiolitis? Anyone?
Sputum production.
Ya, kena sputum production. Most baby mana ada sputum production?
Oh ya.
Macam ni nak diagnose bronchiolitis?
Tak silap saya, kalau bronchiolitis ni dia dia ada noisy and rapid breathing with low grade fever, associated with cough juga.
Dia ada prodromal symptoms and then dia ada prodromal symptoms, dia mesti ada prodromal symptom coryza, and then dia ada dia ada lower respiratory tract symptoms or sign. Contoh dia ada wheezing ke, ada claps ke, tachypnic. Tapi dia mesti ada dia ada few diseases of upper respiratory tract infection punya ni with prodromal symptoms lah, maksudnya either fever ataupun infection lah. And then dia ada lower respiratory tract. Tu kita boleh kata bronchiolitis. So it's very easy actually to diagnose bronchiolitis. It's not a big problem. It's not difficult lah to diagnose bronchiolitis. It's very vague. So you ada budak, contoh ada seorang budak dah 3 hari batuk sesama demam, batuk sesama 3 hari, and then tiba datang dengan rapid breathing sikit. Tapi tak dengar claps atau usually dia mesti akan ada claps atau bronchi, doesn't matter. Tapi dia mesti ada some lower respiratory tract punya findings. Then you boleh kata dia bronchiolitis. Faham tak? Dia tak macam wheezing tau. Dia tak macam viral induced wheeze for example kan. Kalau viral induced wheeze, you mesti kena ada wheezing lah kan. Dia mesti kena ada bronchi. Kalau tak ada, tak boleh kata viral induced wheeze. Tapi kalau untuk bronchiolitis, it's easy. Doesn't matter dia ada bronchi ke, dia ada craps ke, as long as dia ada evidence of lower respiratory tract infection. You faham? Okay. Ada soalan? That's okay, it's good. Ada soalan?
Doktor, macam kalau patient ni kita nak ambil blood culture dia contohnya, tapi dia dah pernah ambil antibiotik 3 kali 1 hari sebelum admission tu. Jadi masih valid ke kalau kita nak ambil blood culture and sensitivity?
Dia usually once dia dah start antibiotik, all culture will be negative lah. Except for meningitis. Meningitis lain sikit. Meningitis, kalau you don't give the correct, contohlah, patient meningitis you bagi gentamicin, then definitely it will still be there lah. Tapi most other side kan, blood, urine, these are, because antibiotic can cross this area kan, can reach this area very easily. So usually after 1 day, you akan dapat negative lah, sterile culture. However, you need to understand why you take blood culture. Kenapa you ambil blood culture before you start antibiotic?
Nak tengok pathogen dan juga antibiotic sensitivity.
Mainly, actually, we don't use blood culture untuk diagnose. We don't use blood culture untuk diagnose. Faham tak? So kalau dia negatif, does it rule out anything? No kan?
No.
Kalau dia positif, dia akan rule in lah. So dia positif, kita tahu this is bacteremia lah. Or sepsis. Tapi dia we don't use blood culture untuk diagnose. Okay, contoh kalau soalan kata, okay, contoh ada soalan lah, dia cakap, soalan cakap pasal bla 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 bla. And what investigation would you send to diagnose the thing? And then kalau you jawab blood culture, then definitely salah lah. We don't use blood culture to diagnose anything. Okay. Most diagnosis is made clinically. Kalau dia kata single answer lah, tapi kalau dia kata what investigations, ada few investigation, then blood culture definitely one of it. Tapi kalau want to confirm diagnosis, maybe blood culture we need. Tapi to diagnose, you don't need blood culture. So usually blood culture kita ambil to determine sensitivity. For example, you ada baby datang dah already take like 5 days augmentin. But then they still datang dengan fever. Do you think the augmentin kills the organism? No kan? Sama-sama maksud dia augmentin doesn't work lah. So kalau you ambil culture, then there still akan ada lah. The organism may possibly be there. Okay? Unless kalau dia partially treated. Then, so you ambil. Tapi contoh you nak decide, you bagi, patient dah augmentin, now you nak tukar, you nak bagi azithromycin. Okay, for example. So the reason you ambil culture is to make sure the organism tu tak resistant to your azithromycin. Memang you start empirical, you start terus. Tapi after 3 days, you balik culture, then you tahu, oh, dia resistant to augmentin. Then you tahu lah, oh, sebenarnya mungkin memang dia resistant from beginning. Ataupun it's actually inadequate dose. Oh, tengok, dia sensitive to augmentin, tapi you dah bagi augmentin, tapi kenapa tak works? Mungkin dia inadequate dose. Itu you akan tengok dia punya MIC semua benda tu lah. Okay, faham kan? Ada ke?
Doktor saya nak tanya regarding treatment dia.
Doktor nak
apa tadi? Tanyalah apa soalan dia?
Doktor nak tanya kalau pneumonia, we want to confirm the diagnosis. Kita buat lavage tak doktor untuk culture untuk dapatkan
to confirm diagnosis is you take biopsy.
I
Okay.
see.
Actually, if you want to confirm diagnosis, you take culture of the tissue, lung tissue culture. Second best is lavage. Lah. Number one, the best is ambil tissue culture lah. You culture the tissue. Second best is you buat lavage. But these are too invasive lah to treat pneumonia. Because pneumonia usually very responsive to treatment. So by the time you nak tunggu result biopsy tu, result culture tu balik, dia dah well lah. So it's no point. Tadi siapa tanya? Afikah Atirah. Sudah. You tanya apa tadi? Apa soalannya?
Regarding the pharmacological treatment of pneumonia,
No.
I'm just wondering because majority of the childhood infection are caused by viral. The causal is viral kan. Tapi kenapa kita treat dengan antibiotics, doktor?
Macam you tahu dia viral?
This is based on data lah macam most. Tapi kenapa kita start dengan
No, I mean
antibiotic?
by clinical macam you nak tahu tu virus?
Tak boleh tahu. Tak boleh
Tak tahu.
differentiate.
Actually most of the data is actually research punya background lah. Faham tak? Maksud dia in clinical kan you cannot distinguish viral dengan ni. It's very difficult to distinguish viral dengan bacterial by clinical. And remember lah you memanglah kita belajar to confirm diagnosis, you ambil this test. But eventually a doctor must, as a doctor you need to diagnose everything by clinical. So you kena understand. For example lah, I campak you pergi satu pulau as a doctor there, MO there. Pulau Perhentian lah as a doctor there. Yang lab pun tak ada. So takkan you tak boleh diagnose everything kan? Takkan you nak tunggu lab punya diagnosis. So you have to diagnose clinically. Itu number one lah. Second, to confirm diagnosis, it takes time. Even with the most advanced lab pun, contoh you nak buat antigen detection untuk virus kan, it takes at least 1 day. So takkan you nak tunggu 1 day baru you decide, antibiotic ke antiviral. Faham tak? And then second, there's a lot of data found co-infection between virus and bacterial, especially in pneumonia lah. Usually maybe kebanyakannya you start with viral, but subsequently you develop bacterial co-infection, superimposed bacterial infection, especially in the setting of RSV. Okay, RSV dia memang ada macam synergis, dia ada macam symbiotic lah, symbiosis dengan pneumococcal. We know those yang infected with RSV, dia akan prone to dapat pneumococcal infection. So usually macam you mention lah, most of time is viral, and usually viral ni dia tak teruk sangat. Tapi kalau dia require admission, sampai sepatutnya in general, once a patient with pneumonia require admission, it means the patient has moderate to severe pneumonia. Mild pneumonia should not require admission. So kalau dia perlu admission, means dia ada moderate to severe pneumonia, and chances are there's more likely that this will be viral. This will be bacterial. Faham tak? Because yang memang data, all the data kita ambil by surveillance. Tapi kita tak buat untuk semua orang. So kita tak tahu. And sepatutnya kalau dia datang hospital means dia memang severe lah, is moderate to severe, which usually caused by bacteria lah. Kalau you baca betul-betul kan, all the surveillance epidemiological data yang kata most are virus kan, most of the time the surveillance done as outpatient. Dia buat kat KK, buat dekat klinik GP. And this outpatient dia tak perlu, they don't require inpatient treatment. So memanglah you nampak viral banyak. Tapi bila you pergi hospital, this are moderate pneumonia, tak banyak surveillance yang buat kat hospital. Satu, because it's very difficult to diagnose pneumonia. You ambil culture, chances are only 10% dia positive. Will lead the bacterial. You buat lavage pun is very difficult. Of course you tak buat lah biopsy. You tak buat culture of tissue. Faham tak? Kita?
Faham doktor. Jadinya boleh ke saya kata principle of management ni memang kita bagi antibiotics sebab most patient macam doktor cakap dia moderate to severe mostly sebab febrile phase ni patient yang kena bakteria kan. Tapi
tak boleh, you tak boleh buat that conclusion. Conclusion dia ialah you judge clinically. Macam tu. Contoh lah, patient kan. Contoh, patient tu bronchiolitis. Bronchiolitis can be intubated tau. Remember bronchiolitis tak semestinya dia tak boleh intubated. You can have a child kan, and datang dengan very bad respiratory distress, tapi dia happy. Contohnya happy wheezer lah. Those yang datang dengan wheezing, very bad wheezing kan. Tapi dia happy. Does it mean dia ada bacterial? Bacterial infection ke selalunya? Not necessarily. So, you kena decide by clinical. You tak boleh kata blanket rule. Usually kita start out. In fact, you tengok clinical lah. Satu, walaupun dia ada quite respiratory distress quite prominent, kan? Tapi you tengok total white dia low. Viral features lah. And then lymphocyte predominant. X-ray pun looks very viral. Dia bukannya patchy tau. Dia looks like homogeneous interstitial punya opacity rather than typical bronchopneumonia or typical lobar. Then you may think this may be virus, so you tak perlu antibiotik pun. Faham tak? You kena ada multiple information lah from investigation, from your history to suggest that this might be. And usually lah bacterially dia take sometimes untuk jadi teruk. Kalau patient kan datang semalam well tiba-tiba datang hari ni teruk, usually is something yang either mechanical or something yang viral. Contoh macam asma lah, mechanical macam choking ataupun asma kan, bronchospasm lah, ataupun is because of virus. Bacterial ni biasa take sometimes. Sebab dia nak migrate daripada one side to one side. Bacterial biasa daripada upper respiratory tract, then dia nak ke bawah, and then dia nak manifest tu, it takes sometimes lah. Faham tak? Okay tak?
Faham, Doktor.
My answering your question.
Yes.
Okay, ada soalan lain? So in exam, okay, ataupun in real life pun lah, in real life, you should have differential lah. Contoh patient tu, you nampak by clinical assessment atau investigation semua, you rasa this is bacterial. Then you start lah, you cakap lah community acquired pneumonia. Okay, tapi your differential would be viral pneumonia. Unless kalau macam total white dia memang dah very high, neutrophil predominant, CRP 20, 30, 100 ke CRP, PCT negative, PCT pun high, then chance procalcitonin high, then chances this is straightforward bacterial lah. Kalau you kata this is viral, then you memang salah lah. Faham? Okay, ada soalan? Respi ni satu yang Aiman paling tak suka sini. Respi neuro. Some people like it lah, some people tak. Tapi it's very clinical lah. Dia tak straightforward macam, dia tak macam endocrine. Endocrine I suka sebab you tak tahu, you hantar the blood, dapat result, okay, confirm. Atau macam cardio, it's very easy. You just echo and then you dapat diagnosis. So simple. Tapi respi, neuro tak macam tu lah. Neuro, patient datang seizure teruk sangat pun, you buat EEG, normal, dia tak rule out epilepsy. Faham tak? EEG may miss. Macam tu lah. Okay, ada soalan lagi? Kalau tak ada dah kot. Okay kan? Okay,
Okay,
so
Doktor.
okay, good. So kita tangguh dengan tasbih kafarah dan suratul Nas. Okay, assalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum
Thank you very much.
warahmatullahi wabarakatuh. Thank you, Doktor.